We've talked about two most prominent intraoperative complications. Now let's move on to postoperative complications. This is postoperative complication. This is pain and swelling. This is because of prolonged surgery time and severe flap retraction during surgery. Also, this can happen when there is a severe bleeding. If bleeding is not controlled appropriately, this kind of complication can occur and ecchymosis can result. If you look at the postoperative pain and swelling, in order to prevent it, atraumatic surgery is key. We need to reduce damage as much as possible. We need to reduce the operation time as much as possible, and gauze bite and pressure dressing is very important. Cold pack and hot pack should be applied accordingly with the different time periods. Appropriate gauze bite is necessary. It needs to be towards the buccal cheek and pressure needs to be applied. The gauze should be applied on the buccal cheek. It should be pressed hard and compression should be applied. Gauze bite is done, and if necessary, pressure dressing should be done. Following pain and swelling, the most frequent postoperative complication we come across is sinus infection. This can be quite baffling. Regarding sinus infection, this is very problematic. How can we prevent it and address it? The incidence rate of sinus infection after sinus bone graft is 2.9%, so about 3%. If you look at the cause, there can be contamination of bone graft material, there can be membrane perforation, graft migration, and periapical infection, and infection caused by hematoma. Also, there can be infection caused by wound dehiscence. When there's problem with the sinus membrane, or if there is maxillary sinusitis, what is most important is the patency of sinus ostium. If there is a sinus ostium patency, in most cases, the problem is not significant. However, if this cannot be ensured, it can be quite disastrous. If there is sinusitis, what kind of symptoms are shown and when does this surface? This is experienced 5 to 7 days after surgery. Problems start to emerge after 7 days, and in most cases, it becomes present in the form of pain due to pressure or nasal discharge. There can be fever and other kinds of complications as shown. If you look at maxillary sinusitis, it is mostly bacterial infection. There can be acute and chronic maxillary sinus, and if acute sinusitis is not appropriately handled, it can advance into chronic sinusitis. There can be bacterial infection secondary to viral infection or fungal infection. These are what consists of sinusitis. Let's look at acute and chronic maxillary sinusitis. It's slightly different. In the case of acute sinusitis, it shows suppurative symptoms. There's a lot of discharge and it comes in a very acute manner. This is secondary to allergic rhinitis. It can also be secondary to acute rhinitis. There can be bacterial infection due to foreign body dislodgement. In the case of chronic sinusitis, this can be a result of a mucopus or pus collection. If you look at the causes, primarily it's because of unresolved acute sinusitis. In the case of acute sinusitis, I've already mentioned the cause, and the sign and symptoms show headache, pain and tenderness, nasal obstruction, and nasal discharge. In the case of treatment, the treatment should include antibiotics. As for acute sinusitis, NSAID can be used. In order to address the discharge, nasal decongestants can be used. Let's look at chronic sinusitis. As mentioned, this can be a result of accumulation of mucus, and this is caused because of unresolved acute sinusitis. Let's look at signs and symptoms. There's a headache. It's a very severe headache. Also, there can be nasal obstruction and discharge. As for treatment, you can use antibiotics. In this case, you need to use it for long term. There can be systemic decongestants, sinus washout, or FESS as well. As for drug treatment, antibiotics, steroids, decongestants, analgesics, antihistamines, nasal spray, and saline irrigation can be used. But you need to think again about antihistamines, and perhaps you can just forget about it. As for surgical treatment, you need to do surgical debridement. After grafting, if there's a problem, you need to remove everything. Caldwell-Luke operation is rarely used. These days, FESS or functional endoscopic sinus surgery is used frequently. When we come across sinus infection, how are we going to address it? First, we need to approach it conservatively using medication. Antibiotics are given. In general, augmentin is prescribed. You can use augmentin as well as other options. There's steroids, analgesics, antihistamine, and decongestant and nasal spray. In the case of antibiotics, the dose of the antibiotic must be high and the duration must be long. So in the case of 375 milligram augmentin, this is used for general purposes, and for sinusitis, you use 625 milligrams. The difference between 625 milligrams and 375 milligrams is the level of amoxicillin content, 500 milligrams and 250 milligrams. You can also use metronidazole, which is specialized for anaerobic bacteria because anaerobic bacteria is the primary cause. You can also use clindamycin or metronidazole. Bear in mind that you need to control both anaerobic and aerobic bacteria at the same time. Augmentin is prescribed in general for about 2 weeks. Despite such prescription, if there's no response, you need to do culture and do antibiotic sensitivity test to change antibiotics. Next is steroid. Systemic steroid is used in general. Local steroid is hardly used. Prednisolone is used about 3 to 4 days. In the case of acute sinusitis, this can be used to reduce swelling, and you use NSAID for analgesics. The reason being, I've mentioned that we need to be careful in using antihistamine because it is contraindication in bacterial sinusitis. So it's better just to forego it. Next, let's look at nasal decongestant. The most frequently used nasal decongestant is pseudoephedrine. After conservative therapy, if problem continues to occur and if the patient has fistula, you need to do IND. When you have done sinus lateral approach, when doing IND, it is important to note that you do not make incision over the area where the window is. Incision needs to be made away from the window. After sinus grafting, if there is swelling and if IND is required, and if there seems to be pus, if you make incision on the window, then oroentral fistula occurs immediately. You need to be aware of this. Third is debridement. You remove everything despite IND if problems continue to persist. Then you need to do re-entry with the original incision line, reflect the flap, and then remove the contaminated graft material. You need to do debridement. When doing debridement, if there is implant placed, such implant needs to be removed. This is a must. If you do not remove it because the implant surface is fully contaminated, then the implant will migrate into the sinus. So you need to remove it at all times. After Debridement, you need to cover using antibiotics and do periodic checkup. After 3 to 4 months, a sinus graft can be performed. You can get such an opportunity at that time point. After debridement, when you do re-entry, the precaution that we need to take is that the window is open because there's very little coverage when there's inflammation. When you make incision, when you detach here, when you elevate periosteal flap, there can be perforation because there's no window. Sinus membrane and oral mucosa are stuck together. If you do blunt dissection, then you'll ruin everything. Therefore, if there's adhesion between sinus membrane and oral mucosa, you need to do sharp dissection using mesh. We need to do elevation using this. If you look at the image, you open full thickness flap up until here, and from here you use a mesh to detach it. If you just reflect the flap, then you'll perforate this area. We need to be careful about that. You can see that there is adhesion here. From here, you need to use mesh to remove adhesion in order to reflect the flap like this without perforation. This is something that we need to be careful about. Membrane is elevated again. The fourth step is to refer to ENT. For FESS, you refer to ENT. In most cases, if things continue to worsen even after debridement, then in such cases, you can assume that ostium patency is not secured, so you need to refer to ENT and do FESS because ostium patency issue can be quite complex. You can do Caldwell-Look operation, but by doing so, you'll enucleate all the sinus membrane. So this is not used these days. These days, FESS is used. People say that FESS is a more conservative approach. However, it isn't. You use intranasal approach and you need to remove concha and other structures to be able to treat it properly. I think this is quite invasive. However, compared with Caldwell-Look operation, it's less so. When you do sinus graft, through FESS, you can preserve graft material and implant, but with Caldwell-Look operation, this is impossible. This is conclusion. If there is problem with sinus, the surgery can become very difficult, but based on my experience, you need to do management as soon as possible. When complication occurs, you need to address it as soon as possible rather than waiting for things to improve on its own. Through a series of steps mentioned, you need to start off with conservative steps. If things don't work out, you need to increase the level and scope of treatment. If inadequate management of postoperative sinus infection is provided, then permanent problems can result. When there's failure of vital bone formation, we need to look at various factors. You need to look back on what kind of graft material you have used. What is most important is that how much contact surface there is between graft material and recipient bed. That is something that we need to think about. And as I've mentioned just now, in order to maximize contact surface between bone and graft material, you need to detach the sinus membrane up to the medial wall and you need to make it in contact with graft material. Appropriate detachment of membrane is crucial. Despite this, if there is failure of vital bone formation, then you can utilize conventional prosthesis like RPD or bridge. If you really want to solve this problem, then you can remove all the graft material that has been applied and try once again. At that time, rather than using xenograft or alloplastic, it is better to use allograft or autogenous bone graft to increase the bone regeneration capability. This is conclusion. If you look at the complications of sinus surgery, the key is in prevention. In order to prevent it, you need to do diagnosis accurately. We need to start off with simple cases rather than jumping into complex cases. By doing this, we can reduce complication incidence. We also need to pay attention in advancing our technique. If such complication occurs, you need to immediately apply appropriate management. I believe this applies in all cases, but more important than anything else is the relation with the patient. If you have good rapport with the patient, even if complications occur, the patient will trust you. Building good relations with the patient is extremely important. Today, we have talked about intraoperative and postoperative complications that can occur after sinus surgery. Today's lecture was quite long, however, we were unable to address all the details. If you're interested in more specifics, please refer to offline master course. I look forward to looking into this topic more in depth with you. Thank you for watching.